It's always a pleasure for me to be back in Sweden, but I will say this time it's actually a little bittersweet because it's sad. I miss Hans Rosling, and I know there wasn't a time I came to Sweden that I didn't get to see Hans. And, you know, he was such a compelling advocate for the field of global health, and he knew how to use data to take very complex problems and break them down so everybody could understand them. And he made data fascinating. One of my friends even said he kind of made being a data nerd geek a really fantastic thing. And I was like, yeah, I think we like those kind of people in our house. The other thing I'll say about Hans is he was just a joy to know. You know, every time I had a conversation with him, it was an adventure. I never knew exactly where we were going, but I knew there was a lesson in there somewhere. So I'd laugh, I'd learn something, and I would always leave inspired. And Hans was a part, but really only one part, of Sweden's outsized impact in global health. For many years, Sweden has been at the top of the list of funding for global health. Many of the institutions we have around the world, the very strong institutions like Gavi, are because of Sweden's long sustained funding. But just as important as your funding is the creativity that you put behind that funding, really pushing the field to be better. For example, Sweden pioneered the idea that gender could be a lens for looking at foreign aid, and that empowering women and girls was a strategic principle. Now the entire field, including our foundation, is coming to understand what Sweden already knew, that pivotal role that girls and women play in development and in societies all over the world. I'd say if there's one really important lesson I've learned in global health in the last 17 years, it's the fundamental importance of putting the girl and the woman at the very center of our agenda. Take the example for a minute of maternal mortality. If you were trying to create the most efficient way to devastate a community, you'd invent something like maternal mortality. But in contrast to that, healthy mothers make very resilient communities. And Sweden is really helping mothers build strong societies by supporting the training of so many midwives in places like Uganda and Bangladesh. Or consider family planning. In countries like Sweden, where contraceptives have already transformed your society, it's kind of easy sometimes, I think, to forget how revolutionary contraceptives are. But when a woman can space and time the births of her pregnancy, it triggers this amazingly virtuous cycle out of poverty. In fact, it's one of the fundamental building blocks that any country that's ever escaped poverty has to offer contraceptives to women. So the healthier women are, the more they can prosper, and in turn, the healthier that their children are and better nourished those children. And as a result, those children can then excel in school and in work and ultimately be more productive in life. So Sweden is investing in that future by making sure that a wide variety of contraceptives are available to meet all women's needs. Because again, we know that if you have a mix of contraceptive methods, women use different contraceptives at different points of their lives. So it's thrilling for me to see the progress that the world is making. Just in the last 5 years, we have 30 million women on contraceptives who would not otherwise have been. And it means there are 300 million women around the world using contraceptives. That's the most in the history of the world. So as exciting as that is, though, there are still big challenges we have to address, and we need to address them soon. So what's next, for instance, in maternal health? Well, the number of mothers delivering babies in facilities is going up. That's a great thing. That's what we've been trying to drive towards as a world. But when you go to those facilities, the quality of the facilities is still not as high as it needs to be. And so we're still seeing babies die at too high of a rate in those healthcare facilities. And those deaths are needless deaths. So in family planning, what's next is we want to make sure that every woman gets the chance to plan and space the birth of her child. But that means making sure that she knows about her body, sexual and human rights are right at the top of your agenda, but also making sure that she knows about contraceptives and she has access consistently to a supply of voluntarily going and getting a contraceptive. So when you think about these big priorities for the future, what makes me so enthusiastic is something like SIGHT. And the students that are here tonight that are part of that. We aren't going to solve new challenges by looking in the same old places. But SIGHT exists so that we can push boundaries, so we can innovate, so we can say to ourselves, what's next, and what's the best way about going against that global health challenge. We desperately need that ingenuity in the field, because I can tell you that the progress that we've seen in the last 20 years is not inevitable, and in fact, it's in jeopardy. It's in jeopardy because the world's commitment to development is at a certain point, a tipping point. And since we've started our foundation, we're starting to see countries say, well, do I really want to invest in global health, or do I want to invest in my own country? Or do I want to invest in global health and not invest in global health and invest in education or invest in climate change? And the answer is we need to do all of those. If countries are to progress, we know it starts with good health, and then it's making sure kids are educated, and then you get a chance to have economic prosperity. So if we're going to promote the health and well-being of people around the world, we have to promote global health. So if somebody asks you whether global health investments are important, I hope you raise your voice loudly and say yes, because you can describe to leaders how development works, explain to them why it's so important for the future we share, and persuade them to keep on funding it. I also hope, though, that you bring forward new ideas, breakthroughs in discovery, development, and delivery, so that we can guarantee that global health continues to be transformative for societies around the world. So I'm very proud to support SIGHT, and I can't wait to see what you all accomplish. Thank you.
Thank you very much, Melinda. Please take a seat. And now I ask the 4 students to please come up and sit. Nice to have you here. A short introduction. Just who are you? Just name and what you work with.
Thank you. So my name is Vera, and I'm a student of economics at the Stockholm School of Economics.
My name is Chantal Avian. I'm a master's student in KTH, majoring in medical engineering.
And my name is Anna. I'm a medical student.
My name is Gustav Alexandri, and I'm a philosophy student.
Great. So you will now, quite short, give a short summary of what you work with, and then we'll have a short discussion. Why don't you start, Anna?
Okay, I think it will be hard to follow that speech, but we'll do our best. As a medical student, a natural starting point for me is how we can improve health. Given that health is a human right and that our health is dependent not only on bacteria and genes, but also on social and political determinants of health, our whole society needs to be involved. In fact, many of the obstacles that we face are not even seen as health issues, such as poverty, lack of education, and climate change. Income disparities within countries are, however, growing, and climate change risks to wipe out all of the development already accomplished. This affects global health, and these issues are urgent. From 2015, we do have the 2030 agenda as a means to work together. But how can we really do this? My question for, I guess, all of us tonight is, how do we collaborate in order to improve health globally?
Thank you very much. Gustav, the stage is yours.
Okay, so as a philosophy student, I think the topic of global health especially brings to mind the works of the Australian moral philosopher Peter Singer. So Peter Singer, he has a very famous moral principle that says that if it is in our power to prevent something really bad from happening without sacrificing anything of comparable moral value, then we ought to do it. So this principle might seem self-evident to many of you, but Singer then turns his attention to the hugely unequal world income distribution. So everyone who's seated in this venue is probably placed in the top 5% or so of the world income distribution, whereas roughly like 10% of the world population still live in extreme poverty. So in the light of this, Singer's principle implies that each one of us ought to spend some of our wealth to reduce extreme poverty. So I'm excited to discuss this with you guys and think about how this connects to the 2030 agenda and how we might sort of work interdisciplinarily to achieve this.
Thank you, Gustav. Vera?
Yes, thank you. So I think Anna made a really excellent point in highlighting the different components and facets of global health. And a natural follow-up question for me is, well, where do we start then? If we agree that every life has equal value and we have limited resources, then we should logically invest in the interventions that save as many lives as possible. And to find the best interventions, we need to rely on research and the evidence that it produces. This matters because the very best interventions are more than 1,000 times as effective compared to the least effective. Previous efforts in diarrhea, malaria, and smallpox have saved each something like 2.5 million lives over the past century. And evidence-based policies have been advocated for a long time by different organizations, and it's something shouldn't come as a surprise that the Gates Foundation have done an excellent job at from the very start. And I look forward to exploring how we can foster even more evidence-based practices within the field of global health.
Thank you. And Tai Lang?
Yep.
You're up.
So when asking why do we students choose medical engineering, most of us will say that we want to help people. Despite the immense advancements in fields such as medical technologies, millions of people still lack adequate health care. During my stay in Nepal as a volunteer technician, I have seen 4 infants sharing one half-functioning incubator due to the lack of maintenance. The failure of transferring technology, where we transfer only machines rather than knowledge, is probably one of the reasons for the unequal access to healthcare. Another reason is that most solutions are designed to satisfy only the high resource settings. Healthcare should be accessible to everyone, but clearly, engineering is not enough. Therefore, I'm thrilled to explore more possibilities with you on how all we can work interdisciplinarily to improve the access to healthcare.
Thank you very much. Would you like to comment any of this, Melinda?
Well, I think they're raising a lot of the really important points that we see in global health. And I think one of the things that I'd like to say that is, when Bill and I first got into this work, and we will, for as long as the foundation exists, we will always believe in the innovation of science. It's not enough, but it is the innovation that moves a field forward. So if you look at why are childhood deaths down, under 5 deaths in the last 20 years, it's because of the innovation of vaccines. It's bringing new vaccines to market, the pneumococcus vaccine, the diarrheal vaccine. Those are the biggest childhood killers. It's because malaria bed nets were brought to market efficiently, the price was dropped, and we actually got parents to hang them up and to sleep under them. That took time, but those 3 tools right there are what's brought down the deaths so much for under 5. So I love that you're bringing up the interrelated, and we can get into that discussion, and I think we should, but it is that belief in the innovation of science and what it will do and what we're already seeing it do for people that makes us optimistic that a lot of these problems can be solved. But you're absolutely right. They can't be solved for high resource settings. They have to be solved for low income settings, and that prices have to be reasonable for people in low income countries.
Exactly.
Now you have the opportunity to ask questions to Melinda. Vera, do you have any question?
Yes, absolutely. So I guess I'm curious about, the Gates Foundation obviously funds a range of different initiatives, from global health and global development on the one side, and also education in the US on the other. So I'm curious to know, Why have you chosen these seemingly quite different approaches to philanthropy, and how would you go about comparing the impact of the two?
So Bill and I have this fundamental belief that all lives have equal value, no matter where they're lived on the planet. And yet, the world doesn't treat all lives as if they have equal value. So we started to say to ourselves, in low-income setting, for every $1,000 we put down, how could we get the greatest impact for the greatest number of people? And as soon as you start to look at that, you look immediately at global health. Because if somebody can start with a healthy life, then they can go on to have an education and to have economic prosperity, to get a job. But if you don't have basic health when you start out, or you're a parent that has a constantly sick child, you are putting all your resources and money and energy, and you're literally going into huge debt to try and save that child. And so we felt like in the developing world, not all people have access to health and to healthcare interventions. So that's the work we do globally outside of the outside of the United States. In the US, we focus on education because we feel like for the most part, people in the US have access to good health care. It's not completely equal, but they have good access. But where we're missing in the US is not every kid has access to high quality education. And so they're not able to go and live the life and bring their talents into the world the way they'd want to. So we are trying to fix the public education system in the United States. And I will tell you, that is the hardest piece of work we do. It's harder than eradicating polio. It's harder than trying to get rid of malaria. It's to fix the US school system. And we will not give up, though. It is that hard.
But why is that harder than polio and other things?
Because it's a very entrenched system in the way the economics of it work and the way the labor unions hold the system in check for adults, and how it's focused on adults doesn't allow the right results for kids. Okay. And when you have that lock by a labor union that you can't get around and you can't get control of, it literally, you can get 1,000 flowers blooming, but the system literally pulls them back down because of the union rules and laws.
Okay. Gustav?
Yeah, so I'd like to tie into both of these topics. There is an issue, of course, with prioritization. There are lots of problems in the world that we need some way to figure out what to prioritize. And one way that philosophers sometimes think about this is to think of it in terms of three factors. So you want to work on a problem that is large in scale, right? So it affects many people, then you can make more progress affecting many people. Another factor that's important, of course, is the solvability. We need to work on problems that are solvable, at least first, so we can. But a third factor that I'm a bit interested in how the Gates Foundation thinks about is the factor of neglectedness. So if you work on a problem where already lots of people or organizations are already working, you might get less of a marginal impact compared to if you go to an area where there's not much people working, so that you can pick the low-hanging fruits. So examples of such areas could be neglected tropical diseases, like it's in the name, but also, for instance, global catastrophic risks, like pandemics, that in periods where there hasn't been a pandemic in a long time, gets very little funding. So does the Gates Foundation think of it in terms of neglectedness in this way?
We do. So if you'd visited the foundation in the early days, probably the first 6 years, we used to literally have flip charts that hung up on the wall, just that white flip chart paper that somebody had taken a marker, and literally you'd go in the room and you'd see the biggest number of, from top to bottom, the top 10 killers of adults, diseases, the top 10 killers of children, and the top 10 DALYs, that is disability adjusted life years, that if somebody got this disease or got this illness, that then they didn't have the chance to live, the life that they wanted. And that literally was our North Star of where we wanted to go. And we started to say, we didn't know we were going to pick off how many of them we're going to pick off, but we said we're going to go learn in all of these various areas and then see, as a philanthropy, we had very much in mind what the role of a philanthropist is, which is very different than the role of a government. And we said, we want to look at each area and see, are there levers that we can find that we think we can fundamentally change that for people? And if so, then we will enter that space. And so that's how we picked off the first, I would say, 8 things that we did. Then, and as things started to come out, like the Copenhagen consensus that said, family planning is literally the best buy in global health, or vaccines is another one of the best buys, we said to ourselves, we're already in vaccines, We were in family planning, but we didn't feel we had the right internal team to move the field forward. So we actually stalled in family planning for a long time. And we learned, when we also felt, Bill and I felt from both of our experience at Microsoft, you have to learn deeply and get good at something before you get to add something else on. So we had kind of 6 areas we were in. And then over time, we started to add as we felt like we had knowledge in vaccines, knowledge in malaria. And the thing that I kept coming back to is family planning. It was disturbing me that I would go out and meet with women all over the world, and they would tell me they knew about contraceptives and didn't have access. And I knew the difference they made in women's lives. And so we came back to that area, and we built the right team inside the foundation, and we decided we would take the political risk and the hit, and that I personally would take that hit because I'm Catholic, because it was worth it for women around the world.
Yeah. We are slightly running out of time, but still, Anna, a short question, and then Thailand also a short question, please.
Okay, then I'm going to turn back into my student perspective. As I guess mainly most of the people here are students and interested in global health issues, we have many opportunities to engage in international settings. And one thing that at least I've learned is that you can learn so much from that meeting that you can achieve when working over cultural barriers or income barriers for that matter. So given that you have a lot of experience in that meeting, is there any kind of learnings that you have gained from low income settings that you feel that you can use in your daily life or in high income settings?
I think you have to be out in the developing world. If you're going to be in the field of global health, you don't know what you're talking about until you go out and spend time in the developing world. So why was Hans so effective? He was effective because he lived in Mozambique for years, and he knew what was going on there. And then he came to his work in data and understanding the importance of data. So I would say to any student, get out there. Get in the, study. You need to study. You need to have your brain all in, but you also have to have your heart all in. And I think until you're in the developing world and you really listen to people and what they're telling you they need and what their needs are, you can't actually make change.
One more question. Now it's you, Thailand.
Yes, we have seen a big change in global health recently, moving from the vertical approach called the Millennium Development Goals to like the whole of the society approach, the 2030 agenda. But however, we as a students will work beyond 2030. So what would you think of, like, let's say 2045 agenda would be like?
Wow. I have to admit, we don't think out quite as far as 2045, although we do say to ourselves as a foundation, we see a day, we're already seeing a day where countries are starting to graduate out of our vaccine programs, because you want countries to be self-sustaining, right? So we're already starting to graduate countries. We will graduate a whole host of countries by 2030. By 2045, what I see is more low-income countries moving towards middle income, being able to tax their citizens and starting to pay for their own health and their own health insurance. When that starts to happen, we'll be able to shift a lot of this money that we're spending in global health to more neglected tropical diseases, to more areas of issues that come up over time. But we have to get countries on that path towards middle-income countries so that this becomes sustainable over time. You can't have constantly this much money coming in from the wealthy world. And South Korea is a perfect example. They used to be a low-income country. They're now middle income, and they give foreign aid because they know the difference that it makes.
First question, Magnus Winter from Global Health Seminar Series asks as follows. Working in cultures that differ from your own, how does the Gates Foundation work around the world, especially on culturally sensitive issues? And you just mentioned you're a Catholic and you still use birth control and so on. So what's your take on that?
So we don't have a staff all over the world. So we work through NGOs, and those non-governmental organizations are on the ground in these countries, and they are the ones who are deeply embedded. We go in with them and listen very deeply, and they're the ones that carry out the work in the community. If you don't have a great relationship with the community, nothing that you do will be sustained over the time. The community might go along with you while you're there and while you're running your program, but as soon as you leave and you pull out, if they don't own it and think of it as theirs and it's not their agenda, it all stops.
But still, there must be situations when you want to do something and the culture says something else, and it's a dilemma.
Yeah, well, here's a perfect one. So in Senegal, family planning, very Muslim population, right? What we do is the government has a goal of spreading contraceptives, but what we do is we work with the imams and we work with the imam network, and what they say is most local imams don't understand at the village level. The Quran actually allows for family planning, and they say it's our job to get that message out. And so we support the imams at the top to get sermons and stories out all the way to the grassroots level. And you have to be patient about that. If I just go in and try to promote family planning, it's going to go nowhere. But these imams get the word out. Then you start to stimulate demand. And at the same time, we're working on supply chain to get the supplies all the way out to the rural level. So when a woman comes in, and then the supply is already there.
Yeah. Thank you. One more question from Caroline Bjunemark from also Global Health Seminar Series. It's a huge topic, but the question is, what do we prioritize in order to provide effective care for the maximum number of people? I realize it's a huge issue, but still.
I think you both invest in the top diseases that people face, but I think you also invest in the primary healthcare system, because when a woman or man comes in with their child, the primary healthcare system is usually about the size of this stage, a little bit smaller. But that's where they go for all their services, whether it's childhood vaccines, whether it's contraceptives, whether it's getting malarial malarial medicine, whether it's learning whether they have HIV. So you have to invest in that primary healthcare system so that it's well stocked, and that the people there are really well trained to recognize the diseases and to take action. And if they don't have the right resources, to move the person very quickly up in the system to the next level of care. But that is where the integrated approach happens.
I have one anonymous question. Why does Gates Foundation show interest in sight? What's in it for you?
What's in it for us are more young global leaders who are a lot younger than Bill and me. And someday we are going to retire. and I look forward to the next set of leadership coming forward and taking this mantle up. So that's what's in it for us, is making sure that global health continues to be a field that's at the forefront with the brightest minds going into it, helping people with the greatest need.
Alexander Silverstolpe wrote as follows: a lot of data is not turned into action by policymakers. How can we close the gap between data, evidence, and policy making?
I think it's really getting government leaders to act on that data and to demand the data, because some of the things that they're funding are inefficient. Some of the things they're funding aren't getting the results that they think that they're getting. So we have to get them to demand data on the things they are funding, and then when they're not getting the results they want, get them to shift the money to things that we know will actually have traction and make a difference.
Magnus Winter, again, he's very active. There's a lot of engagement for global health issues among the students. Mrs. Gates, what would you like to say to us? Any advice?
I would like to say, find where your talents meet the world's greatest need. If you do that, you will stick with whatever it is that you choose, and you can move an area forward. You asked the question about gaps. We go in an area and we pick off the low-hanging fruit. We have been stunned as philanthropists, I mean literally from day one, at how many places that you step into a space and you think somebody must be doing this, somebody must have funded it, somebody must have had this idea that I have, and you find out no, because global health has been, essentially these people have been left behind, right? There are huge gaps. So I promise you there is so much need for your talent, so find where your passion goes and apply your talent.
Can I ask one question that I'm not reading? It's from me myself. I realize you're going to say that we have to be optimistic, but still, do you sometimes feel this is just too much? It's going, so many curves are showing in the wrong direction, and you get sort of pessimistic?
Of course. I mean, I wouldn't be human, right, if I didn't have days like that. And I think those days come, to be honest, for me the most when I'm in the developing world. And it's really important for me to be out in the developing world, not just meeting with governments, which I do in civil society, but to be in villages, to sit down with women on a mat in the dust and to talk about their lives, or to go into a slum and really see what life is like. And I come back on some of those days, quite frankly, overwhelmed and completely heartbroken. Because when you see the violence against women, or you see that but for a seed, they could grow more on their farm, or there's no toilet, yeah, I'm heartbroken. But I think what I try to do on those times is I take a pause in between that trip and coming home, because you need to let your heart break. You have to let your heart break in this work. It's not just about your head and the economic numbers and the charts we have on the wall at the foundation. It's about letting your heart break and say, that could be me. If I was born in that circumstance, what would I want? And you let your heart break, because it also informs and says where you have to go. And believe me, I wanted to turn my back on this family planning field. There are so many times I came out of the developing world and I would hear what women want. And I think I looked for the person who would do it, and I couldn't find them, and I wanted to turn my back. But at the end of the day, you can't. And so by hearing what women said and letting my heart break over that, I knew we had to just step up and step into that space. And it's that sorrow sometimes that I think gives you the courage to know where you need to act.
And one last question from me right now, at least. Can you give a picture of someone you met in a developing country, someone who made an impact on you?
Yeah. There was a woman named Mary Ann, and this was before we got into family planning, but I had sat down with a group of about 24 women. Most of them had a baby in their arms. We were there to talk about vaccines and all kinds of things, but eventually I came around to contraceptives, and we had a very lively discussion. They were willing to tell me a lot I didn't know. And finally, we were kind of near the end, and I think she was worried that I wasn't getting it, and this was in a slum in Nairobi. And she's holding this little baby girl in her arms, and she says, I want every good thing for this child before I have another one. And I thought, that's it. She's encapsulated what every mother wants when they have a baby. Every good thing for their child, and that's universal. And that's what we ought to be able to give women.
Thank you very much.